Hello, everyone. My name is Muhammed Elhadi. I am a clinical research fellow, and also I am pleased to present our recently published meta-analysis in GIE, which is evaluating whether the artificial intelligence-assisted upper GI endoscopy can genuinely help us to improve the neoplasm detection compared to the conventional endoscopy. So we pulled data from around 11 randomized trials encompassing about 58 patients, 1,000 patients. And this work, we believe, addresses very critical questions in gastroenterology, especially given the rise interest in the AI role in diagnostic procedure. And we believe our finding maybe offer some clear insights into the efficacy of this AI in this setting. So let's dive into why our research is very important. So upper GI cancers are devastating, especially when they late found, but they are highly curable when they detect early. And ESD is one of the most operative independent procedure in endoscopy, with documented miss rates even after structured training. So this creates a significant diagnostic gap. And deep learning has already proven its value in colonoscopy, increasing polyp detection. So the question we asked here is whether the same benefit translated into upper GI tract, which can potentially act as a crucial safety net for subtle lesions. So this is a clinical problem we aim to address. So we focused on a pick question restricted on randomized trials. And we restricted our review to randomized trial only. We set specific neoplasm detection rate per patient as our primary outcome. We also included subsets of secondary outcomes such as lesion site, histological grade, procedural quality indicator. This focus with big questions allowed us to rigorously evaluate the impact of the AI-assisted EGD. And this strict methodology was very important to generate reliable evidence, as I will walk through it with you. So our protocol was registered in Prospero before we doing anything else. And of course, we followed the PRISMA guideline with dual independent screening and extraction and the risk of bias. We use a drop2, we use a graded certainty to support our finding. And for some of those like tandem trials, we carefully use it only the first pass data. So we maintain the methodological symmetry with parallel groups RCT. And this, of course, helps us to ensure the robustness of our meta-analysis. So let's look at how rigorous this process has gone. Our initial search has about 5,000 records after reduplication, etc. We ended up with about 11 randomized trials. 10 of these were from China, 1 from Japan. Together, these trials enrolled about 57, about 1,000 patients, which is a large data set, and ensure that our quality of evidence is very good. So let's see the characteristics of these findings. So as you can see that we have some sort of heterogeneity, but there is some sort of consistent comparator here. You can see that the details of each trial here, there's a wide range in the sample size from few hundreds to over about 16,000 in one of the studies. Also see some variety of the AI system, many under EndoAngels or Wissens families. So the comparator in every single trial was either conventional white light or NBI, endoscopy, without AI. This means we are comparing the AI assistance against the standard human practice. So all trial also has some concern of risk of bias, mainly because of endoscopists couldn't be blinded, of course, to the AI overlay. So let's get more into the main finding that we have. So what did we find here? Looking into the primary outcome here, neoplasm detection rate per patient, the AI assistant significantly increased the detection rate. You can see on the left here, we have a risk ratio of 1.57. That means that about 57% relative increase in detection. As you can see, the diamond here sit clearly to the right of the null line of the no effect. So also in the per lesion analysis on the right, we almost have almost identical effect with a risk ratio of 1.55. So both findings here have moderate certainty evidence according to grade assessment, and in absolute terms here, this translates to finding that about 11 patients, more patients with neoplasia per each 1,000 EGD, and 22 more lesions. That mean a very great substantial gain. But where exactly is this benefit from? I mean, why this? What's the benefit coming from? So if you see here, the slide here, in my opinion, the most clinically meaningful impact that AI benefit is overwhelmingly driven mainly by the small lesion. So those who have like 10 millimeters or less, for these lesions, AI more than double the detection with about risk ratio of 2.224. As you can see here, the first plot on the left show this clearly with the diamond far to the right and zero heterogeneity. This high certainty evidence. And for those who have like the larger lesions, which are over 10 millimeters, the detection rate is essentially identical between AI and conventional. And this tells us that AI here act, I would say, like a miss rate reducer. So specifically for the subtle lesions, often flat or early neoplasm that are easily overlooked by the human eyes. And this is precisely where AI add value. And this benefit isn't limited to benign lesion. So if we get more into the other things, I mean, the good news here also continue even if we look on the histology. So if we see here that the AI improves also detection about the entire spectrum of neoplastic change. We see here about 73% increase in LGIN detection, an increase in 61 in even high grade, and 54% in invasive carcinoma. And you can see the first plot here show these consistent benefit, with the diamond all favoring AI. And even for high grade and carcinoma, there is zero heterogeneity, meaning that the effect is remarkably consistent across study. And this is very critical, especially in meta-analysis. That means that AI here isn't just flagging benign mimics. It even detects real and clinically significant neoplasia. And those detection broaden window for endoscopic therapy, of course, and better carcinoma detection rate, which can lead to earlier, potentially curative interventions. And of course, this benefit comes without procedural cost. So if we look into the next slide here, we will see that fewer blind spots by same inspection time, similar like biopsy rate. So from a workflow perspective, I would say that the picture here is very reassuring. AI significantly reduced blind spot by nearly about 4 anatomical sites per case, as you can see on the left here, with the main difference clearly in favoring AI. And this improved mucosal coverage, of course, didn't come at the expense of longer procedural time, because the inspection time was virtually identical between the group, or similar to each other, as shown in the middle plot here. So, and also we didn't see any increase in biopsy rate either, which is a common concern with the AI. So the adverse event here were also similar, or I would say equivalent. And the diagnostic gain is achieved without any procedural penalty, which is a key factor for adoption of this technique. So let's now look where the GI tract of the provide the most benefit. I think the strongest signal, I would say, in the stomach, specifically in cardiofundus body and mid-thoracic esophagus. So we found that this benefit is most pronounced and very clear in region which is very known to be the hardest for the human eye, specifically the cardia and the fundus of the stomach, where retroflexion can be challenging, and the angulus. We see here a strong signal in the mid-thoracic esophagus, where flat, sometimes squamous neoplasia is easily overlooked. The duodenal signal was not significant, but neoplasm rates are extremely low, so these trials are likely underpowered here, as you can see. And this really highlights the AI role in compensating for human visual fatigue, of course, and technical difficulties in these specific areas. And this brings us to the overall strength and limitation of our analysis. So here in our analysis, we see that we have a robust signal, but it's important to acknowledge some limitation. First of all, the geography. The majority of the trial here from China, and they use its same family of AI platform. So we need more prospective Western data and head-to-head comparison of competing system. Also, the magnitude in routine European and North still an open question. We also lacked long-term data on interval cancer rates or mortality. And this is, of course, would be the natural next step for this research. So we need more RCTs, maybe in Western cohort and longitudinal studies, so we can see the real-world impact of this technique. So as we can see here, to summarize our finding, the AI-assisted upper endoscopy here reliably and rigorously improved the neoplasm detection. And of course, it's high certainty miss rate inducer, I would say, and most strikingly specifically for the small and precancerous lesion that drives usually the cancer. Crucially, it does so without, at the time, without biopsies or harm, as you can see here. So we need more pragmatic trials, and that can help us to see if that can be applied in other regional areas and other settings around the world. Thank you again for your time and your attention to our study.